from there in terms of Dr. Siego, how is our country addressing this burden? Because we now know the numbers from what Dr. Atwoli has talked about. So how is Kenya addressing the burden of suicide?
Thank you very much, Mary. Thank you very much, Mary, and the audience. Coming from the Ministry of Health, if you look at this policy, which we launched in 2016, what the Ministry of Health is doing is trying to make sure that key areas are prioritized as part of the strategic actions. And suicide prevention is one of those strategic actions. We know very well that during the 56th Madaraka Day celebration, our head of state, the president, called upon the Ministry of Health, the Ministry of Education, the Ministry of Labor, Youth and Gender, and even went ahead and called upon each individual. The ministries were tasked to come up with a policy. One of the challenges we are facing is, as much as we have the Kenya Mental Health Policy 2015-2030, basically it's the Ministry of Health currently which is trying to handle the whole burden. But we know very well in the countries which have succeeded, you require a multi-sectorial approach, and that's why even this panel is of people from different specialties. So again, what is the Ministry of Health doing? We know that for us to talk about suicide prevention, we need to look at policies, programs, and practices. As part of the strategic action, priority strategic action of preventing suicide, the Ministry of Health is improving access to healthcare. And basically, if we look at the ongoing programs, Dr. Nderi here is leading a program of training primary healthcare workers. We saw yesterday Quality Rights is also supposed, Jackie and Joy are leading that program, is also supposed to make sure that the services we are offering are of good quality. The Ministry of Health is also equipping health workers with competencies in managing suicidal behavior. We are also doing a lot in creating awareness, because we know there's a lot of stigma surrounding suicide and suicidal ideation, so that people can be able to come out and be treated. I've emphasized that as much as we are training primary healthcare, we are currently launching a community mental health program where we are going to reach out to community health workers. In one of the presentations, we'll have World Vision telling us how, in collaboration with the Ministry of Health, they have rolled out problem solving, which is a form of cognitive behavioral therapy for the community health workers who are reaching the community, because we know we have so few psychiatrists, we have so few psychologists, we have very few psychiatric nurses, we have very few social workers, we have very few occupational therapists, and we have few of all the other mental specialists. So we are also training emergency workers and other gatekeepers, including religious leaders, to identify, offer first aid. I know you are all aware about mental health first aid and psychological first aid, and then refer for appropriate treatment. We are also having a program on protection of vulnerable groups, and we also have initiatives to establish crisis helplines. I know we've tried several suicide helplines. We are still looking at what would eventually work at all free line, because currently the reliable ones are at a fee. So that's something which I would want the participants. We also deliberate on it so that we can see how we can all deal with this burden. As I've said, it's not a burden for the Ministry of Health alone. we need different stakeholders to help us with this fight. Thank you very much.
Thank you. Thank you so much, Dr. Siengo. It's good to know that the Ministry of Health is doing a lot on multiple levels and trying to train the existing mental health practitioners to be able to prevent suicide. You mentioned that this has to be a multi-sectoral, a multidisciplinary approach, that everybody has to be involved. So I'll come to you, Gathoni. How can because here we have the media, myself, I'm a clinical psychologist, we have psychiatrists. So how can we all collaborate, and even the people who are not represented on this panel, who are on the ground every day meeting people who die or who attempt suicide? So how can we all, in tongue-in-cheek, get along?
Thank you, Mary. Good morning, everyone. So when we are talking about multi-sectoral, we are basically focusing on the government, the civil society, and the private sector. So for starters, I would like to say that I'm really happy with the move that the government is making in regards to focusing on mental health. This year alone, we've seen a lot of awareness, mental health awareness taking place, and having the ministry putting together this conference is a very, very good move. However, I feel that we need to be more specific in terms of time. We've been having the trainings, we've had of trainings, and boardroom meetings. It is time for us to actually get on the ground and to start implementing these things, beginning from now. Out of from the statistics we've heard, out of the over 3,000 government-owned facilities, only 10% have access, to 29 actually have access to mental health care. We are a country, yesterday we had, from the discussions that were taking place, there's the 98% of people who need to access this mental health care. So we need to see that from the government in regards to putting resources aside specifically for mental health. Let's not forget to talk about, the cost. As much as we are doing all this awareness, we are teaching people of the signs and the symptoms. We know that suicide is a psychiatric emergency. How many people are able to pay, to meet the cost for treatment for mental health? So I feel that that is something that we need to look on. I was happy to hear from the NHIF in regards to what they are going to do. So that's a very good thing. And while the government is concerned, I'm really glad that we are talking about decriminalization of suicide. That is something that we need to focus on and come together as practitioners, as a people, to decriminalize suicide, as well as go to the law and look at the words that are used in the laws of Kenya. Words like imbecile are still there in our laws to refer to people with mental illnesses. So that just continues to increase the stigma. Privately, we need to have both private sectors and government sectors come together. So this is not about, this is all our responsibility. Creating mental health awareness is every single person's responsibility, period. And I feel that we can only achieve this by working together. When we come to the civil society, we are talking about the schools, we are talking about the churches, we are talking about the creative industry, and I feel like so far we are seeing more people being trained in mental health awareness, at least where, for example, where the religious sector is concerned, but we need to see more even from our churches. You know, we are a very religious country and continent. The church is actually the only institution that has access to family as a whole. The people who are there, are they trained professionals to attend to the members of the congregation? I'm happy to see the merge between the creative industry and mental health, you know, trying to how people learn how to express themselves, you know, from a different, you know, perspective. So I feel that the multi-sectoral approach is really going to be perfect in trying to tackle this issue, whereas suicide is concerned, suicide prevention is concerned. So let me also mention one thing also. We say that everybody has a responsibility where mental health and suicide prevention is concerned. Let us be able to be vigilant. What kind of words do we use? We are trying to get people to stop using the words committed suicide to moving to death by suicide. Because once we put the word committed at the front of this act, then we are looking at it as a crime. But if we are able to recognize that so and so died from this, just like the same way they would die from any other disease, then I feel that that would also bring less stigma. And as well as reporting, and I'm glad that we have journalists also in this room. Scientifically, in a scientific room, you can report because you need the statistics. But if you report the means, for example, on TV or on radio, then that is just going to give another person who had tried something else that didn't work an idea of what works. So let also us be vigilant in regards to how we report about suicide, and bearing in mind it's, you know, it's cyclic. So if it happens once, it's likely to happen again.
Thank you.